Ever feel like you're staring at a secret code? That's kind of what it's like when you're looking at an ECG for the first time. All those lines, it's like a whole language about what's going on inside the heart. And believe me, it can tell some pretty wild stories.
Oh, yeah, definitely. It's like a heartbeat's fingerprint. Every bump and dip, it all means something.
Exactly. And just like a detective needs to know how to read those fingerprints, we got to learn how to decode those ECG squiggles.
And that's especially important when we're talking about arrhythmias, those irregular heart rhythms that can be, well, pretty dangerous.
Absolutely. We need to know the difference between a harmless little hiccup and something that needs immediate attention.
That's why today we're diving deep into ECG interpretation, specifically focusing on those different types of arrhythmias. We're going to try to sort through the maze of all those lines and figure out what they're really trying to tell us.
It's like we're on a quest to crack the heart's secret code.
Exactly. And to help us on this quest, we've got a sort of detective's handbook, a guide to ECG interpretation during electrophysiology studies. That's going to be our roadmap through all those squiggles.
Now, this handbook gives us a 12-step method, a step-by-step way to unravel those ECG mysteries. Kind of like a checklist for our cardiac detective work.
It's a good way to make sure we're covering all the bases, dotting all the I's, and crossing all the T's.
Right. So, first things first, step one. How did this whole tachycardia thing even start? Was it like spontaneous? Or was there something that kind of triggered it?
Yeah, that's a crucial first question. If it just started out of the blue, that gives us one set of clues, pointing us toward an automatic tachycardia, meaning the heart's own natural pacemaker is just, well, it's firing too fast.
It's like it's got its foot on the gas pedal, going way over the speed limit.
Exactly. But if there was something that triggered it, like, I don't know, maybe some pacing or something, that points us in a different direction.
More like a re-entrant tachycardia, right?
Exactly. That's when the electrical impulses get kind of stuck in a loop. Makes the heart beat super fast, but it's not really supposed to be doing that. It's like a car going round and round on a roundabout, you know?
Oh yeah, that roundabout analogy, I get it. It's stuck in a loop, can't find the exit. Okay, so that's step one, figuring out the why behind the fast heartbeat. Now, on to step two. We need to figure out the heart rate itself, right? Like, are we talking normal range? Too slow, too fast?
Exactly. Heart rate is crucial. It's like taking the pulse of the situation. But normal can vary a lot, you know? Someone who's really athletic might have a slower resting heart rate, and that's totally fine. But someone with a heart condition might have a fast heart rate even when they're resting. It's all about looking at the whole picture.
So it's like a detective checking out a suspect's background. We need to know the patient's story, their overall health, to really understand what's going on. Okay, on to step three. This one takes us right to the heart of the matter. Literally, we got to analyze the QRS complex.
Ah, yes, the QRS complex. That's where things start to get really interesting. That's the part of the ECG that shows the ventricles contracting, squeezing to pump out the blood.
Okay, so the big question is this QRS complex narrow or wide?
Now, that's the million-dollar question. A narrow QRS complex, that usually means the ventricles are being activated normally, suggesting a supraventricular tachycardia, or SVT.
Okay, so SVT, narrow QRS complex, that's good, right?
Generally, yes, it's like a well-coordinated dance move, everything flowing smoothly. But a wide QRS complex, well, that can throw a wrench in the works.
Uh-oh. Does that mean it's bad news?
Not necessarily. It could mean ventricular tachycardia or VT, which is definitely serious and needs immediate attention. It's like a chaotic dance move, everyone stepping on each other's toes.
Ouch, that doesn't sound good.
But a wide QRS complex could also mean something else, like a bundle branch block. That's kind of like a roadblock in the heart's electrical pathway, slowing down the signal.
So, wide QRS complex, definitely a red flag, but we need more clues to really know what's going on.
Uh-huh.
Okay, so that brings us to step four. Now, if we do have that wide QRS complex, we got to figure out if the rhythm is regular or irregular, right?
Right. We look at the R to R intervals. Basically, the time between each heartbeat, it's like checking the beat of the music. Is it steady or all over the place?
Right, consistent or kind of random.
Exactly. Now, if the rhythm is regular, those R to R intervals are consistent, that could point us to a few things. Ventricular tachycardia, or maybe SVT with aberrancy.
Aberrancy.
Yeah, that's just a fancy way of saying abnormal conduction. Like the signal is taking a detour, but it's still kind of regular.
Okay, I got it. So regular but abnormal.
Right. And we could also be looking at antidromic reciprocating tachycardia. We call that RT for short.
RT, that sounds interesting. What's that all about?
Think of it like an electrical shortcut in the heart. It's an accessory pathway, kind of a bypass route, that makes the impulses skip the normal route and go faster.
Oh, so that's where the fast and tachycardia comes in. It's taking the express lane.
Exactly. So yeah, a regular rhythm with a wide QRS complex could be one of those three suspects. But if the rhythm is irregular, well, that's a whole different ballgame.
So irregular means what exactly?
It's like a chaotic dance floor, no clear pattern. That often makes us think about atrial fibrillation with pre-excitation. The atria, those top chambers of the heart, they're just quivering instead of beating properly, and the impulses are taking that accessory pathway shortcut down to the ventricles. It makes the ventricles beat really fast and irregularly.
Okay, so the regularity of the rhythm gives us another clue. Makes sense. Now on to step 5, and I think this one is all about the P wave, right?
Ah, yes, the P wave. That's the part of the ECG that represents the atria, those top chambers, contracting. It's like the conductor's baton, signaling the atria to start the beat.
Okay, so no P wave means...
Could mean a few things. SVT or VT, or even something called sinus arrest. That's when the heart's natural pacemaker just stops working.
Wow, that sounds serious. So a missing P wave is definitely a bad sign. But what if we do see a P wave? Does that automatically mean everything is okay?
Not so fast. Even with a P wave, we could still be dealing with SVT, VT, or even RT. It's like the P wave alone isn't enough to solve the case. We got to put it together with all the other clues we've gathered to really get a diagnosis.
Like pieces of a puzzle.
Exactly. Each step, each finding adds another piece to the puzzle, getting us closer to the complete picture.
I like that, the puzzle analogy. Okay, so before we move on to those next steps in our ECG detective work, I want to take a quick minute to give a shout out to London HeartbeatsZ Academy in the UK. They're doing some awesome work in healthcare education, and they have over 140 healthcare courses, from ECG interpretation to all sorts of advanced stuff.
They're great. They really know their stuff.
And they've got a really active online presence, too, sharing free updates, discussions, all sorts of cool stuff on their social media channels, Facebook, Instagram, Spotify, YouTube. So yeah, definitely check them out if you want to learn more about all things heart-related. All right, back to our ECG puzzle. Step 6, this one gets into the relationship between the P wave and the QRS complex, right?
Right. We want to know, is there one P wave for every QRS complex? Are they in sync?
Okay, so what if they're not?
Well, if it's not a one-to-one relationship, it could mean we're looking at an SVT that's happening only in the atrium, like atrial flutter or atrial tachycardia. Could see multiple P waves for every QRS complex. It's like having two conductors trying to lead the orchestra at the same time.
Two conductors. That sounds like a recipe for disaster.
It can be. Or we could be dealing with ventricular tachycardia, where the ventricles are just going rogue, contracting without any input from the atria. Like the percussion section decided to do their own thing, totally ignoring the conductor.
Okay, so a mismatch between the P waves and the QRS complexes could mean a problem in the atria or a takeover by the ventricles.
Right. But what if they are in sync? One P wave for each QRS complex. Does that mean we're in the clear?
I was about to ask that. So what if it looks synchronized?
Well, it could be a well-behaved SVT, especially if we've got a wide QRS complex that's suggesting a bundle branch block. But it could also be VT with one-to-one retrograde conduction.
Retrograde. So it's going backwards.
Exactly. Each ventricular beat is followed by an atrial signal. It creates this illusion of synchrony, but it's not really how it's supposed to work.
Sneaky.
And then there's our old friend RT, antidromic reciprocating tachycardia. That accessory pathway can create a loop that includes both the atria and ventricles. So even if it looks synchronized, we got to dig a little deeper to be sure.
So even if it looks like they're dancing together, it could be a very deceptive dance.
Exactly. Sometimes it's hard to tell just by looking if there's truly a one-to-one relationship between the atria and the ventricles.
Okay, so how do we figure that out? Our detective's handbook must have a trick for this.
It does. We can use medications like adenosine or verapamil. They temporarily block conduction through the AV node. Think of it like closing the gate between two sections of the dance floor.
Separating the dancers.
Exactly. Now, if that separation leads to AV dissociation, the atria and ventricles are doing their own thing, and the QRS complex stays wide, that's a big clue that it's VT. Like the ventricles are leading the rogue dance party.
Okay, so that's how we unmask the ventricles. But what if they stay in sync even when we close the gate?
That points us towards SVT with a bundle branch block, or maybe ART. They're still dancing together even though the gate is closed.
So adenosine and verapamil, Those are like truth serums, helping us see what's really going on.
Exactly.
But how can we tell the difference between a bundle branch block and RT if everything is still in sync?
That's where the his signal comes in, our little microphone inside the heart. It lets us listen in on the electrical activity as it travels through the his bundle, a key part of the conduction system.
So we're eavesdropping on the heart's electrical conversations.
Right. Now, if the his to ventricle interval, the time it takes for the signal to go from the his bundle to the ventricles, is normal, that tells us it's probably a bundle branch block. The signal is just taking a little longer to get there, like hitting a bit of traffic.
Okay, so normal travel time, just a little delay.
But if that interval is super short, like 0 or even negative, that's a good sign that it's RT. The signal is taking a shortcut getting to the ventricles faster than it should.
Like lipping through a secret passageway. So his signal, it's our way of figuring out if the signal is taking the scenic route or the express lane.
Exactly.
Okay, on to step 7. This one's all about the shape of the P wave, the P wave morphology.
Right. We want to know, is it consistent? Is it the same shape as we'd see in a normal sinus rhythm, or is it inverted, biphasic?
Biphasic, meaning?
Meaning it has 2 distinct phases, like 2 bumps instead of 1.
Okay, so why does the shape matter?
It's like analyzing the conductor's style. Is it smooth and flowing, or is it all over the place? If the P wave doesn't look like it does in a normal sinus rhythm, it tells us the rhythm isn't coming from the sinus node, the heart's natural pacemaker. Someone else has taken over the conductor's podium.
So a weird-looking P wave is suspicious.
Exactly. But what if it looks normal? Does that mean we're good to go?
That's what I was wondering.
Not necessarily. It could be sinus tachycardia, where the sinus node is just beating faster than usual, like it's excited about something. Or it could be something called inappropriate sinus tachycardia or sinus node reentrant tachycardia. The sinus node is still in charge, but it's either overdoing it or it's stuck in a loop.
Okay, so even a normal-looking P wave doesn't mean everything is peachy. We got to look at the bigger picture. Now, what if the P wave morphology isn't the same all the time? Like it keeps changing shape.
That usually means things are a bit chaotic. It could be atrial fibrillation where the atria are just quivering instead of contracting properly. It's like the conductor has completely lost control and everyone's playing whatever they want.
Atrial fibrillation, yeah, that's one we hear about a lot.
Right. But what if the P wave is consistently the same, but it's not the normal sinus rhythm shape?
Okay, so consistent but off. What does that tell us?
That could be a bunch of different things. SVT, sinus tachycardia, inappropriate sinus tachycardia, sinus node reentrant tachycardia, VT, even RT. It's like a substitute conductor. Maybe they have a different style, but they're still managing to keep the orchestra playing together.
So it narrows down the possibilities, but we still need more clues. Now, the handbook also mentions that the shape of the P wave can tell us about the direction of the electrical impulse. Can you explain that?
Sure. If the P wave isn't inverted, it means the impulse is traveling in the normal direction, from the atria to the ventricles. Like the conductor's signal is flowing smoothly to the orchestra. Could be atrial tachycardia, VT with AV dissociation, sinus tachycardia, or sinus tachycardia with aberrant conduction.
Okay, so normal direction, everything's moving forward.
Yeah.
What if the P wave is inverted?
That means the impulse is going backwards from the ventricles to the atria. Like the orchestra is playing the music in reverse. We often see that in orthodromic reciprocating tachycardia, or ORT.
ORT, another tachycardia to add to our list.
Right. Now, what about a biphasic P wave, the one with 2 dumps? What does that tell us?
Yeah, what's the deal with those 2 bumps?
That usually means there's an intra-atrial reentrant rhythm. The impulse is just circling around within the atria, kind of like the conductor's signal is bouncing back and forth between sections of the orchestra instead of flowing smoothly.
Okay, so a localized loop in the atria. And if it's not biphasic?
Well, that could be a whole bunch of other things, like atrial tachycardia, VT, sinus tachycardia with aberrant conduction, AVNRT, ORT, even ART. It's like the signal is traveling more straightforwardly, but we still need more clues to figure out exactly what's going on.
So another piece of the puzzle, but not the whole picture. Okay, on to step 8. And this time we're looking at the PR interval.
Right. That's the time between the start of the P wave and the start of the QRS complex. Basically, it's measuring how long it takes for the signal to get from the atria to the ventricles. And we want to know, is it always the same? Is it consistent?
Okay, so what does a consistent PR interval tell us?
Consistent PR interval, that's a good sign. Means the atria and ventricles are working together, beating in sync, like a well-coordinated dance routine. Could see that in ORT, VT, with 1-to-1 retrograde conduction, RT, or AVNRT.
Okay, so good communication between the atria and ventricles. But what if it's not consistent? What if it's all over the place?
Inconsistent PR interval. That means the atria and the ventricles aren't quite on the same page. They're not beating synchronously, like the dancers are out of step, one doing their own thing while the other is trying to follow a different rhythm. Could be a sign of VT, Wonka-Bach, which is a type of heart block, or atrial fibrillation.
Okay, so inconsistent PR interval, that's another red flag. Means there's a lack of coordination between the atria and the ventricles. Got it. Now, step 6B. This one mentions checking the His bundle recording for a clear intraatrial trace. What's that all about?
Right, so this is about getting a closer look at what's happening in the atria. We want to see if we can spot that atrial signal in the His bundle recording.
Okay, so it's like zooming in on the atria. And then step 7B, this one's about the AV relationship.
Yes. We want to know, is it regular? Normal? If it is, that suggests normal anterograde conduction, meaning the impulse is going from the atria to the ventricles through the normal pathway, like it's supposed to.
Okay, so everything's flowing in the right direction. What if it's not regular?
If the AV relationship is irregular, that means there's something disrupting the normal flow. Could be VT, where the ventricles are taking over, atrial fibrillation, where the atrias are just a mess, or Wonka-Bach, that heart block, where some impulses are getting blocked.
Got it. So the AV relationship tells us if the signal is following the rules or breaking them.
Exactly.
Now on to step 8B. This one's all about the VA relationship.
Ah, the VA relationship. Here, we're looking at the connection between the ventricles and the atria. Is there VA conduction? Meaning, is the impulse traveling from the ventricles back up to the atria?
Okay, so it's like the signal is going in reverse.
Right. Now, if we do see VA conduction, it could be SVT or VT. The signal is going backwards, kind of like driving the wrong way down a one-way street.
Against the flow.
Exactly. But if there's no VA conduction, it could mean an atrial arrhythmia that's not going backwards, VT, where the signal is starting in the ventricles, or atrial fibrillation, where everything is just so chaotic that the signal gets lost.
Okay, so VA conduction, it gives us another piece of the puzzle about the direction of the signal.
Right.
On to step 9, and I think this is where we ask if there's a His tracing for every QRS complex.
Yes. This is a big one. If there's a His tracing for every QRS complex, it means the electrical impulse is traveling through the normal conduction system, whether it's going forward, anterograde, or backward retrograde. It's like the traveler's either taking the main road or the scenic route back, but they're still on the map. This could be SVT or VT with one-to-one retrograde conduction.
Okay, so the signal's playing by the rules, even if it's going in reverse.
Yeah.
But what if there's no His tracing for every QRS complex?
That's a sign that the signal is taking a detour off the beaten path, like the traveler decided to go off-roading. This is a hallmark of VT without retrograde conduction. The ventricles are just making their own impulses, completely ignoring the atria.
So, no, His tracing means the ventricles are going rogue. Okay, now we're on to step 10, and this is all about the His to ventricle interval.
Right. Remember our little microphone in the heart? Well, this interval tells us how long it takes for the signal to travel from the His bundle to the ventricles. Now, if it's normal, that means the wide QRS complex we might be seeing is caused by a bundle branch block, not ventricular pre-excitation. That's where an accessory pathway is speeding up the signal. So this would point us toward SVT with a bundle branch block.
Okay, so normal interval means it's taking the scenic route, not a shortcut. What if the interval is abnormally short?
If it's super short, like 0 or even negative, that's a strong sign of ventricular pre-excitation, our friend RT making another appearance. It's taking the shortcut, bypassing the normal route, and getting to the ventricles faster than it should.
So the His to ventricle interval, it's like checking the signal's travel time. Helps us figure out if it's running late or speeding.
Exactly.
Now, step 11. This one asks about the location of the first atrial signal after the QRS complex. Why does that matter?
It's all about pinpointing the origin of the arrhythmia, figuring out where it's coming from. Now, if that first atrial signal is at the SA node, that tells us it's coming from the heart's natural pacemaker.
So everything's starting in the right place.
Right. But if it's at the His bundle, that means it's going backwards, up the fast pathway. Like it's taking the express lane in reverse.
Going against traffic.
Exactly. And if it's in the post-receptal region, it could be retrograde conduction up the slow pathway, or maybe a bypass tract, or even a ectopic atrial tachycardia that's starting in that area.
Yeah.
Like it's either taking the back roads back or it's starting in a weird spot.
So the location of that first atrial signal, it's like finding the source of the river where it all begins.
Right.
Okay, last step, number 12. And this one's about the location of the last atrial signal after the QRS complex.
This step gives us even more information about the conduction pathway. If that last atrial signal is at the SA node, It could mean retrograde conduction through the AV node, an accessory pathway, or even an ectopic site on the tricuspid or mitral valves. Like the signal is taking a detour back, either through the normal gateway, a shortcut, or a weird exit.
So many possibilities.
If that last signal is at the His bundle, it could be orthodromic reentrant tachycardia, a sinus origin, or an ectopic site up high in the right atrium. Like the signal is either circling in a loop coming from the natural pacemaker or starting in a weird spot. A posterolateral location might mean atrial flutter, where the signal is circulating in a specific pattern within the atria. And if it's recorded in the coronary sinus, it could be antidromic reentrant tachycardia through a left-sided accessory pathway. The signal's taking a shortcut on the left side of the heart.
Okay, so the location of that last atrial signal helps us map out the pathway and figure out what kind of arrhythmia we're dealing with.
Exactly.
Wow, we just went through all 12 steps. That was a lot of information.
Yeah. It was quite a journey, wasn't it? But I think you can see how each step is important for understanding the ECG and figuring out what's going on with the heart.
Absolutely. It's like we've learned a whole new language, the language of the heart's electrical system.
And now we can use that language to decode those ECG squiggles and understand those irregular rhythms.
Exactly. So, are you ready to put our newfound knowledge to the test?
Bring it on. Let's see what those ECGs have to tell us.
I like your enthusiasm.
Let's dive right into some cases. We'll start with figures A1 and A2. They show a tachycardia with a wide QRS complex.
All right, so figure A1, it's the 12-lead ECG, right?
Yeah.
And yeah, I see that wide QRS complex. It looks like it has a right bundle branch block pattern, too.
Exactly. You can tell it's a right bundle branch block because of that positive V1 lead. And the QRS complex, definitely wide. Plus, the positive lead I and negative AVF, that suggests a left axis deviation, meaning the heart's electrical activity is kind of tilted to the left.
Interesting. Now, figure A2 shows the intracardiac electrograms. Those are the recordings from inside the heart, right?
Right. And the big thing here is AV dissociation. Remember we talked about the atria and ventricles doing their own thing, dancing to different tunes?
Yeah, like they're not talking to each other.
Exactly. And that's what we're seeing here. The atria and ventricles are contracting independently.
Okay, so we've got the wide QRS complex, the right bundle branch block, and now AV dissociation. What does that all point to?
All signs point to ventricular tachycardia.
Ventricular tachycardia. Wow, that's serious stuff. It's amazing how these lines can tell such a big story.
Absolutely. Now let's move on to figures B1 and B2, another case of wide QRS complex tachycardia.
Okay, figure B1, I'm not seeing any clear P waves here. It's kind of just a jumble.
Yeah, the P waves are hidden, if they're even there at all. They're buried within those QRS and T waves. We've got a right bundle branch block again, positive V1 lead, and that left axis deviation like the last case.
Okay, so no P waves, wide QRS, right bundle branch block.
Yeah.
What about figure B2, the intracardiac electrogram? What's that telling us?
This time we're seeing the atrial and ventricular waves happening at the same time, and that His to ventricle interval is normal. That tells us there's normal antegrade conduction, meaning the signal's traveling from the atria to the ventricles the way it's supposed to. No shortcuts this time.
No shortcuts, but the report mentions a prolonged AH interval and a short HA interval. What's that all about?
Those intervals tell us about the conduction through the AV node. Remember, that's the gatekeeper between the atria and ventricles. A prolonged AH interval means the signal's taking a bit longer to get through the AV node going forward, probably using that slow pathway. But then, the short HA interval, that means it's zipping back quickly from the ventricles to the atria using the fast pathway.
So it's like taking the scenic route there and then the express lane back.
Exactly. And if we look at the activation pattern, we see the earliest atrial activation happening at the proximal His bundle, while the latest activation's in the high right atrium and distal coronary sinus.
Okay, so putting it all together, what's the diagnosis this time?
Based on all that, it's AVNRT with a right bundle branch block.
AVNRT. Okay. Now let's move on to figures C1 and C2. This is a wide QRS complex tachycardia with a left bundle branch block pattern.
Right, so this time we've got a negative V1 lead, which means a left bundle branch block, but the axis deviation is still to the left, positively I, negative AVF.
Okay, so this time the roadblock's on the left side. What about the intracardiac electrograms in figure C2?
We're seeing normal His to ventricle intervals, meaning the signal's going down the AV node, the usual route. But the VA interval, the time for the signal to go from the ventricles back to the atria, that's longer than 60 milliseconds. Tells us it's not likely to be AVNRT.
Interesting. So normal conduction down, but a slow trip back. Anything else?
Yeah, look at the earliest atrial activation. It's happening at coronary sinus catheters 5-6. Remember, the coronary sinus gives us information about the left atrium, so this is pointing to a left-sided accessory pathway, a shortcut on the left side of the heart.
So the signal's taking a detour on the left.
Precisely. And because the is bundle enrol atrial activation happened way later than those coronary sinus recordings, we can rule out AVNRT, atrial flutter, or atrial tachycardia.
Okay, so what's our diagnosis then?
Everything points to orthodromic AVRT with a left bundle branch block.
Orthodromic AVRT, meaning the signal's going down the AV node and then back up through that accessory pathway. It's amazing how we can track that whole path.
It is pretty amazing. Okay, let's move on to figures D1 and D2. This is showing a wide QRS tachycardia with a right bundle branch block pattern, and we've got a 2.1 AV ratio here.
All right, so figure D1. Right bundle branch block, positive V1 lead, and this time the axis deviation is to the right, negative lead I and positive AVF. And you said a 2.1 AV ratio.
Right, that's important. It means for every 2 atrial beats, there's only 1 ventricular beat. That pretty much rules out an accessory pathway and makes ventricular tachycardia less likely.
So we're dealing with a blocked signal, not a shortcut this time.
Exactly. Now look at the intracardiac electrograms in figure D2. Where's the earliest atrial activation happening?
Looks like it's near the coronary sinus ostium, specifically at catheters 9-10.
Right. And that coronary sinus ostium activation happening before the proximal his bundle atrial wave, that tells us we've got a counterclockwise activation pattern. That's a classic sign of common atrial flutter.
So typical atrial flutter with a right bundle branch block.
You got.
Atrial flutter, it's like a fast, organized dance, but only in the atria.
That's a great way to put it. All right, moving on to figures E1 and E2. This one's showing a wide QRS complex tachycardia, again with a right bundle branch block pattern, but this time with pre-excitation.
Okay, so figure E1, I see that right bundle branch block again, positive V1 lead, and a right axis deviation like the last case. But I'm seeing P waves this time. They're kind of buried in the T waves.
You're right. Those hidden P waves are a clue that something interesting's happening. Now take a look at the intracardiac electrograms in figure E2. What do you see?
I'm seeing a short HV time. Didn't we say that usually means pre-excitation?
You got it. Short HV time means the ventricles are getting activated earlier than they should, which means there's got to be an accessory pathway.
Right, because it's taking a shortcut. And the report says the earliest ventricular waves is at coronary sinus catheters 3-4.
Exactly. That tells us exactly where that accessory pathway is, confirming the diagnosis of antidromic reentrant tachycardia with pre-excitation.
Antidromic reentrant tachycardia. It's amazing how we can track the signal through the heart and pinpoint that pathway.
It really is. Now, let's move on to figures VTA1, VTA2, VTB1, and VTB2. These are examples of ventricular tachycardia with those bundle branch block patterns.
Okay, so VT masquerading as bundle branch blocks.
Right. Figures VTA1 and VTA2, we see a right bundle branch block pattern in that 12-lead ECG, positive V1 lead, and a right axis deviation. So that means VT with a right bundle branch block.
Got it. So what about figures VTB1 and VTB2?
Same idea, but this time it's a left bundle branch block pattern. Negative V1 lead, left axis deviation, VT with a left bundle branch block.
So ventricular tachycardia can look like either a right or left bundle branch block. That's something to keep in mind.
Definitely. Okay, now let's look at figures 1A, 1B, 1C, and 1D. These are showing us how we can induce AVNRT using extra stimulus pacing.
Extra stimulus pacing, what's that exactly?
It's a technique where we deliver an extra electrical impulse to the heart. We're basically giving it a little nudge to see how it responds.
So we're kind of poking it to see what happens.
Exactly. So figure 1A, we see the intracardiac electrograms with extra stimulus pacing. The basic cycle length is 500 milliseconds, and the S1, S2 interval is 350 milliseconds.
Okay, yeah, what do those numbers actually mean?
The basic cycle length, that's just the regular heartbeat interval. And the S1, S2 interval is the time between the first regular beat, which we call S1, and that extra stimulus, which is S2. We use those intervals to create specific conditions and see what the heart does.
So we're controlling the electrical environment to steady the heart. Clever.
Right. Now, figure 1B shows the same pacing, but with a slightly shorter S1, S2 interval, 340 milliseconds. And the key here is there's an AH jump of 150 milliseconds.
An AH jump, what does that mean?
The H interval is the time between the atrial signal A and the his bundle signal H. When we see a sudden jump in that interval during this extra stimulus pacing, that's a big sign of AVNRT.
So that AH jump, it's like a fingerprint for AVNRT.
Exactly. Now, figures 1C and 1D are showing us the same pacing but at different speeds, but the main point is still the same. We're inducing AV-nRT. The earliest atrial activation is at the His bundle, which means it's going backwards through that fast pathway, and the atria and ventricles are being activated at the same time.
So visual confirmation of AV-nRT.
Right. Let's move on to figure 2A. This one's showing ventricular extrastimulus pacing, remember, where we're giving the ventricles a little nudge.
Okay, so now we're poking the ventricles.
Exactly. And what we see here is decremental VA conduction. That means the conduction from the ventricles back to the atria is slowing down with each extra stimulus. Suggests retrograde conduction through the AV node, the usual way back to the atria.
Decremental conduction, so the signal's getting weaker as it goes back. Interesting.
Okay, figures 3A and 3B are showing us induction of AV-nRT again, but this time using both ventricular and atrial extrastimulus pacing.
So we're trying different ways to trigger AV-nRT. What's the result?
Well, in figure 3A, with ventricular extrastimulus pacing, we see that decremental VA conduction again, which points to retrograde conduction through the AV node. And we also see concentric activation. That means the atrial activation is spreading outwards from a central point.
Okay, so ventricular pacing shows us the retrograde conduction and how the activation spreads. What about atrial pacing?
Right, so figure 3B, we're using double atrial extrastimuli, basically giving the atria 2 quick nudges. And guess what? We induce AV-nRT again.
So both ventricular and atrial pacing can trigger AV-nRT.
Exactly. The important thing is that the earliest atrial activation is consistently happening at the His bundle, which means it's going back through that fast pathway. And we see simultaneous activation of the atria and ventricles. That's a hallmark of AV-nRT.
Like we're putting together the pieces of the puzzle, and each pacing maneuver gives us another piece.
Exactly. Now let's look at figure 4A. This is showing induction of AV-nRT again, using atrial extrastimulus pacing.
Okay, so more atrial pacing. What are we seeing this time?
Same as before, we're inducing AV-nRT, earliest atrial activation at the His bundle, retrograde conduction through the fast pathway, simultaneous activation of the atria and ventricles.
So this is just reinforcing the AV-nRT diagnosis.
It is, but it also highlights something important. Sometimes it can be tricky to tell which wave is the atrial wave and which is the ventricular wave. In this case, the best way to do that is to look back at the signals from the last S1 beat, the regular beat that happened before the extra stimulus.
So we use the normal beat as a reference point.
Exactly. Okay, let's look at figures 5A, 5B, and 5C. These are showing us induction of both common and atypical AV-nRT using atrial extrastimulus pacing.
So different flavors of AV-nRT.
Right. Figure 5A, that's our classic common AV-nRT. Earliest atrial activation at the His bundle, retrograde conduction through the fast pathway, everything happening at the same time.
Okay, so that's the usual suspect. What about atypical AV-nRT? What makes it different?
Well, in figure 5B, we see a slightly different pattern. The tachycardia has a relatively normal AH interval and a longer HA interval.
Okay, so what does that mean?
It suggests that the signal's going down the fast pathway and then back up the slow pathway. It's still AV-nRT, but it's the atypical kind.
So different route, same destination. And figure 5C, that confirms the atypical AV-nRT, right?
Exactly. We see the earliest atrial activation happening at coronary sinus catheters 9-10, which supports that idea of retrograde conduction up the slow pathway.
It's like the signal's taking the scenic route instead of the highway. Okay, let's move on. What's next?
Okay, now we're looking at figures 6A1, 6A2, 6A3, and 6A4. These are showing us how we identify a left lateral accessory pathway. We're using ventricular extrastimulus pacing and ventricular pacing.
So back to those accessory pathways.
Right. Figure 6A1, we deliver a ventricular extrastimulus, and that narrowest AV interval is recorded on coronary sinus catheters 1-2. Remember, the coronary sinus tells us about the left atrium.
So that narrow AV interval in the coronary sinus, that means?
Left lateral accessory pathway.
Got it. And figure 6A2 is showing us the same thing with another ventricular extrastimulus.
Exactly. See how the earliest atrial activation is in the distal coronary sinus? That's another sign of that left lateral pathway.
Okay, I'm seeing it. Now what about figure 6A3?
This time we see a VA jump. That means the time between the ventricular signal and the atrial signal suddenly increases.
Why does it do that?
It happens because the extra stimulus falls within the accessory pathway's refractory period. It's like the pathway's busy, it can't handle another signal right now.
Okay, so the signal can't use the shortcut because it's occupied.
Right. So the activation shifts to the AV node. That's the usual way back to the atria. You can see that the earliest atrial activation is now happening at the His bundle.
So it's forced to take the scenic route.
Exactly. Now, figure 6A4, this is showing straight ventricular pacing. We're just delivering a series of paced beats to the ventricles.
Okay, and what are we seeing?
Notice how the coronary sinus atrial waves, those represent the left atrial activation. They're happening before the His bundle activation. That confirms conduction up a left lateral accessory pathway.
So even with regular pacing, we can see that pathway. What's the diagnosis in this case?
Based on all of that, it's Wolff-Parkinson-White syndrome, or WPW syndrome, with a left lateral accessory pathway.
WPW syndrome, okay. It's amazing how we can use these figures and these pacing techniques to pinpoint the location of that pathway.
It is pretty amazing.
Yeah.
Now let's move on to figures 6B1, 6B2, and 6B3. We're looking at induction of orthodromic AVRT using atrial extrastimulus pacing.
So now we're triggering the kind of AVRT where the signal goes down the AV node and then back up the accessory pathway.
Right. In figure 6B1, we deliver an atrial extrastimulus, and that induces orthodromic AVRT. It's basically blocking conduction in the fast pathway.
Creating a roadblock on the express lane so the signal has to take a detour?
Exactly. And you can see that those distal coronary sinus atrial waves are happening before the His bundle activation. That confirms conduction up that left lateral accessory pathway.
In figures 6B2 and 6B3, those are just showing the same orthodromic AVRT at different speeds.
Right. Main point's the same. Earliest atrial activation in the distal coronary sinus, then the His bundle, then the high right atrium, orthodromic AVRT using a left lateral accessory pathway.
Okay, so a visual tour of the signal's journey through the heart.
Now let's look at figures 6C1 and 6C2, more induction of orthodromic AVRT with atrial extrastimulus pacing.
All right, so more of the same. What's different about these figures?
Not much, really. We're seeing the same pattern. Atrial extrastimulus pacing induces orthodromic AVRT by blocking that conduction in the fast pathway. Distal coronary sinus atrial waves happening before the His bundle activation, confirming that left lateral accessory pathway.
So just more confirmation of that WPW syndrome with the left lateral accessory pathway.
Exactly. Okay, now figure 7. This one's showing us orthodromic AVRT again, but this time using a left postreceptal accessory pathway. Again, triggered by atrial extrastimulus pacing.
So different location for the accessory pathway this time.
Right. This time it's left postreceptal. Notice how coronary sinus catheters 7 to 8 have the earliest atrial waves, and they're happening before the His bundle activation. Classic orthodromic AVRT using this particular pathway.
So the location of those earliest atrial waves, that's how we pinpoint the pathway.
Exactly. And that normal HV interval tells us that the conduction is happening down the AV node, the usual route.
But the report mentions some other maneuvers. What are those all about?
Right, so to be extra sure about this diagnosis, we could do things like perihesian pacing, or give adenosine, or even do ventricular pacing during His bundle refractoriness. These maneuvers give us more information about the conduction pathway and help rule out other possibilities.
So it's like getting a second opinion.
Exactly. Okay, now figure 8. Orthodromic AVRT again, but this time using a left septal accessory pathway, triggered by, you guessed it, atrial extrastimulus pacing.
Another left-sided pathway, but this time it's septal.
Right, and what we see is very similar to the last case. Atrial extrastimulus pacing, orthodromic AVRT, and the earliest atrial waves are on coronary sinus catheters 9-10. That confirms that left septal accessory pathway.
Okay, so same story, different location.
Exactly. Now figure 9, this one's showing orthodromic AVRT with the earliest atrial activation coming from the distal pair of electrodes on a 20-pole catheter in the coronary sinus, specifically at the left posterolateral coronary sinus.
Okay, so we're using a different kind of catheter to get a better look.
Right. A 20-pole catheter lets us record from multiple spots in the coronary sinus, so we get a more detailed map.
What does that map tell us?
Well, those earliest atrial waves are coming from those distal electrodes, and they're happening before the His bundle activation. Plus that normal HV interval, that all confirms orthodromic AVRT using a left postreceptal accessory pathway.
So we're getting a much more precise location with this 20-pole catheter.
Exactly. Okay, now figures 10A, 10B, 10C, and 10D. We're looking at orthodromic AVRT again, but this time we're seeing some different conduction patterns. We're trying to locate that left lateral accessory pathway.
Okay, so same pathway, different patterns. What are we seeing here?
In figure 10A, the earliest atrial activation is at coronary sinus catheters 3-4, confirming that left lateral pathway. HV interval's normal, so we know the signal's going down the AV node.
So classic orthodromic AVRT.
Right. But figure 10B, we see orthodromic AVRT with a right bundle branch block. Now, this is interesting because that bundle branch block is happening on the opposite side of the accessory pathway.
So the signal's taking a detour on the left, and there's a roadblock on the right. What does it tell us?
It actually tells us a lot. The normal HV interval tells us it's not antidromic EVRT, and the shorter tachycardia cycle length means it's not a right-sided accessory pathway. There's something called Kiemel's law. It says that if a bundle branch block happens on the same side as the accessory pathway, that tachycardia cycle length increases.
So Kiemel's law helps us figure out if the pathway's on the left or the right, based on the cycle length and the bundle branch block.
Exactly. So in this case, it's orthodromic AVRT using that left lateral accessory pathway, and it's got a right bundle branch block along for the ride.
Okay, that's fascinating. Now, figures 10C and 10D, those are just showing the same tachycardia at different speeds, and we see a long AH interval. What does that long interval mean?
It means the signal's taking a bit longer to get through the AV node going forward, maybe using a slower pathway. And in 10D, they've moved the coronary sinus catheter a bit further to get a better look at that accessory pathway. The earliest atrial activation is now happening between catheter 7, 8, and 9, 10, so we've got a more precise location.
Like zooming in on a map to find that shortcut.
That's exactly. Okay, moving on to figures 11A and 11B. This time it's orthodromic AVRT with a left posterior accessory pathway, and we're seeing different conduction patterns again.
All right, so another left-sided pathway, but this time it's posterior.
Right. Figure 11A, earliest atrial activation is at coronary sinus catheters 5, 6, which confirms that left posterior pathway. HV interval is normal, so it's conduction down the AV node.
Classic orthodromic AVRT. Got it. What about figure 11B?
Figure 11B, we see orthodromic AVRT with a left bundle branch block. Remember Kiemel's law? Well, the tachycardia cycle length increases during the bundle branch block, and that confirms that it's a left-sided accessory pathway.
Okay, so the left bundle branch block plus the longer cycle length, that points to the left posterior pathway.
Right. Now we're going to look at figures 12A, 12B, 12C, 12D, 12E, 12F1, 12F2, and 12G. Lots of figures here, but they're all showing us how we identify and ablate a right-sided accessory pathway.
Okay, so we're going to see an ablation. What exactly does that mean?
Ablation means we're using radiofrequency energy to make a tiny scar in the heart tissue. We're basically disabling that problematic pathway.
So it's like a tiny targeted surgery.
Exactly. Okay, so figure 12A, this is showing sinus rhythm, the normal heart rhythm, but we can see evidence of that right-sided accessory pathway. We see a delta wave, that's a slurred upstroke on the QRS complex, and the earliest ventricular wave is happening at the His bundle, which tells us it's not a left-sided pathway.
Okay, so the delta wave and that early ventricular activation, those are clues that the pathway is on the right side. What else are we seeing?
That negative delta wave in lead V1, that's another clue. And a short HV interval, minus 37 milliseconds, that confirms pre-excitation.
So lots of signs pointing to a right-sided pathway. Figures 12B and 12C, those are just showing that same pre-excitation pattern at different speeds and during ventricular pacing.
Right, and notice that during the pacing, the earliest atrial activation is still happening at the His bundle. That confirms it's a right-sided pathway. But now the high right atrium is showing the latest atrial activation, and the left-sided coronary sinus electrograms are delayed too.
So pacing really helps us visualize how that signal's traveling.
It does. Now, figures 12D and 12E, those are showing ventricular extrastimuli, and the shortest VA interval is always at the His bundle, confirming that right-sided pathway again.
Okay, so more confirmation of the pathway.
Right. Now, here comes the exciting part. Ablation time. Figure 12F1, we're applying that radiofrequency energy, and poof, the delta wave disappears.
Just like that, no more shortcut.
Exactly. Notice how the HV interval is now normal. That means no more pre-excitation. And figures 12F2 and 12G, those are just confirming that the delta wave is gone and the HV interval is normal after the ablation.
So the ablation was a success. The right-sided pathway is closed for business.
Exactly. Now, the report mentions that to be extra precise with the ablation, they could do some more mapping on the right side of the heart using a duodecapolar catheter or an ablation catheter.
So it's like using a more detailed map to guide the ablation.
Right. Okay, now we're going to look at figures 13A1, 13A2, 13B1, 13B2, 13C1, and 13C2. This is a case of orthodromic AVRT, but this time there are multiple accessory pathways involved.
Multiple pathways. That sounds complicated.
It can be. Figure 13A1, that's a 12-lead ECG during orthodromic AVRT, and figure 13A2, those are the intracardiac electrograms. See how the distal coronary sinus recordings look kind of fused together?
Yeah, I see it.
That suggests there's a left-sided accessory pathway.
Okay, so a shortcut on the left.
But there's another pathway, too. Figure 13B1, this is showing atrial pacing, Remember, we're delivering paced beats to the atria. This is showing us what antidromic reciprocating tachycardia, or ART-D, would look like in this patient, because RT involves antegrade conduction down the accessory pathway.
So we're trying to trigger RT by pacing the atria.
Right. And in figure 13b2, we're seeing some confusing results from that coronary sinus catheter. Makes us think there might be more than one pathway involved.
More than one shortcut. So what does figure 13c1 show?
Figure 13c1, this is a 12-lead ECG, and it doesn't look like it has maximal pre-excitation, meaning that accessory pathway isn't fully activated. But it does have a wider QRS complex compared to figure 13a1. That makes us think about ART.
Okay, so maybe ART, but we're not sure yet.
Right. Now, figure 13c2, those are the intracardiac electrograms, and we see the earliest ventricular activation is at the distal coronary sinus, where the atrial and ventricular signals are fused together. That confirms we've got ART, and it matches up with the orthodromic AVRT.
So this patient has two accessory pathways.
Exactly. They have a left lateral accessory pathway that's causing both the orthodromic AVRT and the RT, and they also have a left post-receptal accessory pathway. That one wasn't active during the tachycardia, but it showed up during the pacing.
Wow, two for the price of one. It's incredible how we can uncover all these hidden pathways. Okay, what's next?
Next, we're going to look at figures 14A, 14B1, 14B2, 14C2, 14C3, 14D2, 14E1, 14E2, 14F, 14G, 14H1, and 14H2. Deep breath, lots of figures, but they're all about identifying and ablating a left lateral accessory pathway.
Okay, back to a single pathway, but this time we get to see the ablation in action.
Right. So figure 14A, that's a 12-lead ECG during sinus rhythm, and we see a positive delta wave in lead V1 suggests a left-sided accessory pathway. Figures 14B1 and 14B2, those are the intracardiac electrograms before ablation, and the earliest ventricular wave that's happening between coronary sinus catheters 3, 4, and 5, 6, which confirms that left lateral pathway.
Okay, so we're zeroing in on that pathway. What happens next?
Figure 14C1, that's a 12-lead ECG during orthodromic AVRT. Notice how it's got a narrow QRS complex, looks really different from the ECG in 14A. Figures 14C2 and 14C3, those are the intracardiac electrograms during orthodromic AVRT, and they're confirming that left lateral accessory pathway.
Okay, so we're seeing the tachycardia, and we've confirmed the pathway. Now, figures 14D1 and 14D2, these are showing atrial extrastimuli. And we're seeing both a small delta wave and a large delta wave depending on the timing of that extra stimulus. Why is that?
It shows us how dynamic pre-excitation can be. The size of that delta wave, it can change depending on how that accessory pathway is being activated.
So the delta wave, it's not always the same.
Interesting.
Now, figures 14E1 and 14E2, these are showing the intracardiac electrograms during tachycardia. We see those fused electrograms at the distal electrodes of the ablation catheter. Could be an accessory pathway potential?
So we're getting closer to the target for ablation.
Right. Figure 14F, this is a recording from the distal electrode of the ablation catheter during sinus rhythm, and we see that accessory pathway potential. That's our target.
We found the culprit.
And now for the big moment. Figure 14G, we see that delta wave disappearing during RF energy delivery.
The shortcut's gone. What do the post-ablation figures show? Figures 14H1 and 14H2, those are showing us the intracardiac electrograms and a 1.12 lead ECG after ablation. No more delta wave, normal HV interval, successful ablation of that left lateral accessory pathway.
It's amazing what they can do these days. Okay, so what's next?
Figures 15A1, 15A2, 15B1, 15B2, 15C1, 15C2, 15D1, and 15D2. This time we're looking at a Mahem fiber.
A Mahem fiber, what's that?
It's basically another kind of accessory pathway, connects the atria to the ventricles, usually bypasses the AV node.
Okay, so another shortcut.
Right. Figures 15A1 and 15A2 show a left bundle branch block pre-excitation pattern. So there's pre-excitation, but instead of a regular delta wave, it's causing a left bundle branch block. The HV interval is kind of borderline, so it's not a slam dunk.
A little more subtle this time.
Exactly. Now figures 15B1 and 15B2 show constant atrial pacing, and that makes the left bundle branch block pattern even more obvious. Now the HV interval is 0, so that confirms pre-excitation.
So the pacing helps us see it more clearly.
Right. Now, figures 15C1 and 15C2 show atrial extrastimuli, and we see decremental conduction. That means the conduction through the Mahem fiber is getting slower with each extra stimulus.
Like it's running out of steam.
Exactly. Now, figure 15D1 shows a recording from the ablation catheter, and we see a Mahem fiber potential. That's a specific signal that tells us that's the target. Figure 15D2 shows RF energy delivery during atrial pacing, After ablation, we see a narrow QRS complex, and that Maham fiber potential's gone.
So ablation 1, Maham fiber 0.
You got it. Now let's move on to figure 16A1, 16A2, 16A3, 16B1, 16C1, and 16C2. These show ablation of common atrial flutter.
Okay, back to atrial flutter.
This is your 16A1, common atrial flutter with counterclockwise activation. That's the usual pattern. Figures 16A2 and 16A3 show pacing from different spots in the coronary sinus during sinus rhythm. This shows us something called isthmus conduction. That's a specific electrical pathway in the atria that keeps that atrial flutter going.
So we found the electrical circuit that's causing the problem.
Exactly. Now, figure 16B1, this shows termination of the tachycardia during RF energy delivery. But this doesn't always mean the ablation was successful. We got to make sure that pathway is really blocked.
So just stopping the flutter isn't enough.
Right. Figures 16C1 and 16C2 show pacing after RF ablation, and they show us block in the isthmus, confirming bidirectional conduction block. That means the signal can't travel through that pathway anymore. No more atrial flutter.
We broke the circuit.
We did. Okay, moving on to figure 17. This one's showing uncommon atrial flutter. It's got clockwise atrial activation, so it's still atrial flutter, but the signal's going in the opposite direction.
The atria are doing the wave in reverse.
Exactly. Figure 18, this one shows atypical atrial flutter. Could be forming around an atriotomy scar.
An atriotomy scar.
Yeah, it's a scar left behind after heart surgery. Sometimes those scars can mess with the heart's electrical system, create these weird pathways that cause atypical flutter patterns. This figure is showing potential sagittal septal atrial activation, which means the signal's moving in a weird direction, maybe around that scar.
So scars can really disrupt the heart's electrical flow.
They can. Now, figure 19, this one shows atrial flutter in the right atrium and atrial fibrillation in the left atrium. So one part of the heart is doing this fast, organized dance, and the other part's just in total chaos.
Wow, two completely different rhythms at the same time. How can you even tell?
Those erratic atrial electrograms from the coronary sinus catheter, that tells us it's atrial fibrillation in the left atrium.
So the coronary sinus is giving us a peek into the left atrium.
Exactly. Okay, last one. Figure 20 shows atrial fibrillation in both atria, so both upper chambers are just quivering. Total electrical chaos.
Atrial fibrillation in both atria. Wow, that's a lot to take in.
It is, and that brings us to the end of our ECG exploration.
What a journey. I feel like we've learned so much about the heart's electrical system, all those pathways, the shortcuts, the detours. It's amazing how it all works together.
It's a complex system, that's for sure, but it's fascinating, isn't it?
Absolutely. And seeing how we can use pacing, medication, and mapping to figure out exactly what's going on, and then ablation to fix those problems, it's really incredible.
It's like we've become heart whisperers, understanding its secret language.
Exactly. So before we wrap up, I just want to say a huge thank you to London HeartbeatsZ Academy for their support in helping us put this deep dive together. They're doing amazing work in healthcare education, so definitely check out their courses and resources.
Yes, they're fantastic.
And if you want to learn more about the heart and all its amazing intricacies, make sure to check out London HeartbeatsZ Academy's website and social media channels. They're on Facebook, Instagram, Spotify, and YouTube. They got tons of great information, and it's all free.
They're a great resource for anyone who wants to learn more about cardiology.
Absolutely. Well, that's all the time we have for today. Thanks for joining us on this deep dive into the world of ECG interpretation and arrhythmias.
It's been a pleasure.
We'll be back soon with another deep dive into a different fascinating topic, so make sure to subscribe and stay tuned. Until then, keep those brains buzzing and never stop learning.